My name is Meredith Agan. I lead the analytics team here at Comagine Health. I'm very excited that there's people signing in, and I'm not just alone in my basement presenting to no one, so thank you. We're really excited to share with you the advanced analytics that we're working through for COVID-related analyses. As we go through our slideshow today, feel free to ask questions. We have two chat masters, so Lisa Miller and Megan Haggard will be hoping to answer as many questions as possible. Feel free to chat into everyone if you feel comfortable. So I think it's by default it goes to all panelists, but definitely chat into all panelists and attendees. I'm also joined by Jeff Hummel and Sarah Halvick today, so I'm excited that my teammates will be able to kind of share more with you as we go on. So I'm going to go to the next slide. So just as a quick overview of what we're going to cover is that we're going to kind of go over Comagine Health. You might know us by a different name. So I think we just want to make sure that you're aware of who we are and what we do. We're also going to go through our approach for COVID-related analytics, and then what we're doing now and what we're planning to do next. So as we're prepping for kind of the grander design of what to do for the next 12 to 18 months. So Comagine Health, you might know us by Qualis Health and Health Insight. We are a national nonprofit healthcare consulting firm. So we pride ourselves in being a neutral party that is able to solve healthcare issues of any kind. We have a robust team of over 400 people that have many different skill sets. So we jump into any issue. So that's why we're happy to kind of share with you all of our skill sets and what we can walk through. So our services are surrounded by our work. We work on advanced analytics, research and evaluation, system-wide quality improvement, health information technology consulting, and care management. We're also spread across the entire country. So we do have a heavy representation on the West Coast, but we're definitely branching out every day. For Comagine Health Analytics services, we have a wide array of services, and they're all centered around that middle vision of healthcare reimagined together. So as we think about the levers that we are hoping to push on to create better outcomes, so more equity in the healthcare system, better healthcare outcomes, reduced costs, and improved health, we do many different types of services, including value-based care consulting, hotspotting and population health, total cost of care consulting and analyses, health data literacy and consulting. We link data sets, we create enterprise solutioning. So if you need an analytic platform to be able to do public reporting, where we pride ourselves in being able to do that and do that well. We do intervention impact analyses, academic research, survey design, and data collaborative. So bringing everyone together and collecting ideas. So there's a fair and balanced sort of approach of how you share data and how you represent data. So for COVID-19, we have many different arms that are working on different types of projects. So today you'll hear about advanced analytics. We also have contact tracing. We have infection prevention and control, and telehealth and virtual services. So if you have interest in any of those areas, feel free to chat that in. Feel free to ask us any questions whenever you want. So for our first polling question, before we get started, we just want to be able to ask, is your organization running any COVID-related analytics in-house? So are you doing it every day or almost every day, sometimes, or not that much or none at all? So Janine, are we able to share the results?
Yes, we have a few people still voting, and then I'll share the results.
I like seeing that people are chatting in already. So people who are doing the daily tracking every day, that's awesome. Mm-hmm. Oh, wow. There's a hefty portion are doing a lot of analytics. So it's exciting to see that people are using the data they have to try to get as much information as possible. So just to orient ourselves, the type of analytics that we're hoping to do for around COVID and in the broader category of all the folks that are being impacted by COVID, we really enjoy this wave chart, which Victor Sang, a physician, posted on Twitter very early in the pandemic. So he actually had these nice waves showing the overall sort of impact, right? So there's the first wave of the immediate morbidity and mortality of COVID-19. So that acute event of having COVID. Then there's the second wave of reducing resource restrictions, right? So for urgent but non-COVID related conditions, what is happening to those patients? For example, we've seen that patients are not presenting in the EDs with stroke or heart attack. So it's interesting to see what's happening with those patients and how are they getting the care they need. Also, the third wave, which is thinking about chronic care conditions and what is the impact of deferred care. So for patients that have congestive heart failure or diabetes, how is their conditions being handled or being managed over time, and are they suffering negative outcomes because of it? And then there's the fourth wave that really hits everyone, right? So everyone is being affected right now by social isolation. A lot of people are being affected right now by losing their jobs or losing their income. And then most people are being affected by just being burnt out, right? So if they have a job that they have to work 8 hours a day, plus they're taking care of their children or anyone else, then they're stretched a little too thin, right? So in this wave, we're really particularly thinking about everyone that could be impacted. And then also there's patients that are dealing with suicide, suicide intentions. We have folks that are dealing with domestic violence right now. We have folks that are already struggle with opioids, and what is happening with those patients? Are they getting the services and the care that they need? Or are they suffering negative outcomes that could be avoided? So I think as we oriented ourselves to this, we're thinking not just of the immediate events of COVID-19, but the overall sort of impact of what this pandemic is having on the larger population. So what data do we bring to the table, right? So we have data from many different sides, and we pull it together to create one sort of puzzle, right? So we have clinical data, we have claims data, we have public and complementary data, which really pulls in that economic survey data, the area deprivation index, our shortage areas, because we know that there's a lot of areas that just don't have providers that are readily available and you have access to. And then we also have patient voice. So as patients are kind of voicing what's happening in their environments, we're making sure that we're pulling any of that public information in. And then I think I am handing over to Jeff Hummel, who's a medical director here, and he's really been helping us guide our sort of clinical perspective as we're going through our analyses.
Thank you, Meredith. So we're going to talk about these second, third, and fourth waves in more detail. But first, imagine something with me for just a moment. If you'd been living in Europe, say in a small town in France in 1350, when the bubonic plague swept through in successive waves over a 4-year period with a mortality of somewhere around 20% each time it came through, you would not have needed a sophisticated data and reporting and analytics system to know what was happening on a day-to-day basis, because the impact of the pandemic would have been everywhere you looked. Part of the challenge we face with COVID-19 is that unless you're in a community or a workplace in which a large percentage of the population is ill, or you're working, let's say, in a healthcare environment that concentrates seriously ill COVID-19 patients, like in an ED or an ICU in the Bronx, it can be very difficult to actually see what's going on from your own personal experience. So for this epidemic, we have to rely on data to understand the disease patterns and understand what treatments and preventive measures are effective in limiting and reducing mortality. There are a lot of things about this pandemic that are unique, and we're having to be really creative in our use of data to track disease outbreaks, to evaluate the effectiveness of our efforts to control them, and to plan for what may come next. And a lot of what may come next is actually predictable. The healthcare system has, of necessity, focused on the acute complications of this initial wave of COVID-19. The public policy response, also of necessity, is focused on limiting spread by shutting down whole segments of the economy. And the majority of people appear to understand the risk that contact with others brings to themselves and the people they need to protect and have been adhering to this. But staying home in semi-isolation means that a lot of other non-COVID-19 related health issues are going unmet, which can only go on for so long before we start to get outside our safety zone. Operating outside one's safety zone is an abstract concept with very real consequences. It can be really difficult to tell when you've crossed that invisible boundary and are now all of a sudden operating in an environment that's unsafe. And then it's only a matter of time before something bad happens. And there are a lot of historic examples of this, perhaps the most spectacular being the Space Shuttle Challenger explosion. And even the severity of the COVID-19 pandemic itself is due in part to operating outside of our safety zone, despite plenty of warnings to the contrary. So let's imagine that we might...
Jeff, can you speak a little closer to the mic? We got a couple of comments to...
Oh, I'm sorry.
No, you're good. Let
me just turn up my volume and make sure it's all the way up. It is. Okay, I'm sorry. So let's imagine what might happen if we suspend care, usual care for some important health conditions on account of the COVID-19 pandemic. And let's try to think of ways that we might be able to tell if we've moved beyond our safety zone. And let's talk about ways to prevent more bad things from happening. So on the next slide, you'll see what I've done here is list some of the conditions that would need to be on our radar. This is a busy slide, so we're going to go through it in a little bit of detail. On the left-hand side, under the topic clinical issues, I've listed 3 topics that, regardless of everything else that we need to be paying attention to, are certainly going to be on the list. One is immunizations, because COVID-19 is not the only infectious disease out there that we need to be concerned about. Below that, I've listed diabetes and other chronic conditions, and then behavioral health. And what I want to do is go through each of these and look at, in the columns to the right of that, what are the risks that we face if we take our eyes off these challenges while paying attention to COVID-19. Next to that is, what are the data flags that we might use in order to tell if we're moving outside of our safety zone. And then finally, on the far right, what are some strategies that we might want to put in place early on, or fortify if we're already using these techniques, so that we are prepared to respond to bad things that may happen if we start to move outside the safety zone. So immunizations are really an important one, and I'm including both childhood and adult immunizations in this. Childhood immunizations are complicated. There are a lot of them, and the whole purpose is to prevent outbreaks of preventable childhood illnesses. And some of these are serious illnesses. Rubiola or measles has a significant mortality rate to it. Polio as well has a significant morbidity rate in terms of paralytic polio. It's interesting in the sense that the number of complications from polio is very similar to COVID-19. The vast majority of cases are actually asymptomatic, but we keep these under control by immunizations. With influenza and pneumococcus, the risks is primarily in older people, and when immunizations don't occur regularly, people die. So that's the risk. How might we tell if immunizations are falling off because people aren't coming in to get to be immunized? Well, this can be challenging. However, immunization rates can be tracked. It's difficult because we don't always know the denominator, but we know how many immunizations are being given because most states have registries. In fact, all states have some sort of registry in which immunizations are tracked, and the majority of them do get documented there. So we could certainly look at any reduction in immunization rates. The other thing is that the supply chain of immunizations can be monitored. lot number was. And when they need more immunizations, they order more. I'm getting a note that my internet connection is unstable. Hopefully this will not be a problem. So in planning strategies, one thing we might do is expand the sites that are authorized to give immunizations that of course have to have a reliable two-way exchange to the registry. And of course, we need to have analytics in which we can identify the areas of greatest need where immunizations may be dropping off. Let's turn our attention to chronic illnesses. Diabetes, of course, is sort of the flagship one that most places pay attention to, but other chronic diseases operate much the same way, such as asthma, heart failure, risk factors for cardiovascular disease, and chronic renal disease. For each of those, there is what the risk is that we will lose control of a primary physiologic parameter that we pay attention to. So for example, in diabetes, what we worry about is loss of glycemic control, or in asthma, loss of control of airway spasm, loss of control of weight for weight gain in the case of heart failure, or impaired renal function getting worse in renal failure. And so and the way this would then impact us, or impact the system and impact patients, more importantly, is the number of cardiovascular events. And this could result in emergency utilization and hospitalization for events that could easily have been prevented and normally would be. So the data flags that we would be able to pay attention to would be reduced patient contact. Normally, primary care practices are trying to reach out to patients with chronic illness. And if those patient contacts are reduced, it might be possible to know that from electronic health record information. Another place we could look at would be refill data on medications, because many of these chronic illnesses are controlled with medications. And then if there starts to be an increase in urgent and emergency care utilization, not necessarily just in the emergency department, but even calls to consulting nurses, that might be an indication that things are starting to move, get dangerously out of control. Planning strategies, population health is probably the core here. Having a registry for each practice for who the people are with these illnesses, and being able to track which ones have care gaps and reaching out to them. This can be done with care management, or with virtual visits and remote monitoring. There's a real need for peer support networks. They're very effective in many of these chronic illnesses where patients are actually looking out for each other. And increasingly, we're seeing community health workers and other peer support being very effective in reaching out to patients with chronic illnesses. And of course, we need the analytics to identify the areas of greatest need. The third one I want to make sure we cover is behavioral health. And the risks here span quite a spectrum of different conditions, from depression and anxiety to serious mental illness. The risks, of course, are things like suicide and suicide gestures. Domestic violence, we have already seen evidence that with people remaining at home and being confined at home, there's the frustration, and that leads to increases of domestic violence. Substance use disorder may very well increase. There's a lot of indications that that's already happening. And I'm sure that there are many risks in addition to these. The data flags are almost identical in many ways to chronic illnesses. Reduced patient contact, refill data are the other things that we can look at, because many of chronic depression conditions and other serious mental illnesses have meds that need to be refilled. And then again, increasing calls for help, whether that's to a helpline or a crisis clinic, or actually to an urgent care facility. And again, the ways that we can really build a resiliency into the system to handle this is by strengthening work that's already started with behavioral health integration between primary care and behavioral health, care management, again, with virtual visits and remote monitoring, and expanding links to community resources that are still available telephonically, even if people are confined at home. And then lastly, not to be forgotten, is we need the analytics to be able to tell where we are. This is really about being able to see in what would otherwise be a kind of blind situation. I've mentioned these three topics because they are important, but there are others. Pregnancy, one can easily imagine how failing to get first trimester prenatal care could easily lead to complications of pregnancy, whether it's low birth weight or premature birth or other poor outcomes. Frail elderly is an area where there's a lot of risk, and cancer screening. There's a concern that if we're not doing regular cancer screening, then we may start to see more late case presentations. So what I'd like to do next is turn to the next slide and just let you folks tell us what you think the most pressing clinical topics would be. Did we hit on the right ones? Where should we be putting our emphasis? Where are you putting your emphasis? How can we help?
And definitely feel free to chat in if you have other anything that you think we're just missing that we haven't already identified.
We have a couple of comments in the chat. Other ideas include homelessness population, the second wave of COVID, staff wellness or illness, and then reopening safely while still preparing for other surges.
Thank you for bringing up those new topics particularly. I really like the one about staff wellness, because clearly the primary care had, even going into this pandemic, there was plenty of evidence of high levels of burnout and stress among primary care staff. And I think we need to really be very, very cognizant of the stress that that's having. The other one that I think is related to that is the fact that with the decrease in utilization in medical services, what's happened is a lot of medical support staff and clinicians as well have been laid off or furloughed, and that they are then suffering the economic stress of that. So there's clearly plenty of reason to be concerned about the well-being of the staff. The emphasis on the homeless is great. I mean, there are so many social issues on this that are complicating it. One thing we didn't put in there as a wave, but obviously is kind of on everybody's mind, is social unrest and what happens and how does the healthcare system respond to that. And we're certainly having another think about that. Other thoughts or questions that people might want to talk about?
A couple more suggestions were to think about child abuse, which is on the rise, along with alcohol consumption, and then looking at underserved populations in general.
Right. I mean, that's clearly a thing. When we first went into this pandemic, and a lot of the risk factors that you still see being published today because of the lag time. I think one just came out in the New England Journal early this week saying, here's the risk factors for a poor outcome with COVID-19, and they were all age-related and chronic illness-related. And since that initial picture evolved, what we've seen, of course, is a very high disproportionate impact on communities of color and minorities, which when you do the when you standardize for socioeconomic status, it's very clear that it has nothing to do with ethnicity or race. It is all socioeconomic status. So what we're seeing is the impact of this pandemic on our population based on other factors that have discriminated against particular ethnic groups, and it's quite striking.
I can take us through now as I go to the next slide is what we're doing right now. So just to get you started, there is some public content that we've been sharing. So we have on our website, if you go to comagin.org, we do have maps that we are sharing using Medicare fee-for-service data, which includes 6 states. So that's Idaho, New Mexico, Nevada, Oregon, Utah, and Washington. So we have that data, and we're able to pull out the COVID-19 comorbidities, and we're able to show where are the hotspots around each state as to how many patients have those chronic conditions, so that it allows patients, allows us to be able to kind of figure out where are the places where we need to kind of hunker down on different resources. We overlay that data with our hospital information, so we know the hospital capacity for each area. So we're kind of overlaying that data, the regular hospital capacity. We're happy to kind of allow you to click in and drill around. So if there's anything additional that you'd like to see in this sort of visual, we're happy to kind of share it. We have this for Medicare fee-for-service data. We also have it for our Oregon all-payer claims database. So you're able to see a wider swath of the population too. So it's an interesting way to be able to kind of toggle between both Medicare and our all-payer claims database for Oregon too. So that's a public content that we've pulled together, and we're improving it every day. So we're excited to see people kind of click around and see what else they need. For our Indian Health Services, we have a contract where we work on the partnership for tribal health. So that project is a collaboration between CMS and the Indian Health Services, and our team is pushing out daily reports using public content, but taking public content from many different places. To be able to provide a sort of a snapshot each day so that you can see how are the cases sort of rising up and where are they, where are the trends, right? So we particularly see it in Navajo Nation that there's a fast escalation of the number of cases, and then how are the overall trends working out. So this is public content that we tee up directly to Indian Health Services. The other piece is that we are drilling into particular populations, right? So we know that there are different rates of cases and deaths related to COVID if we look at different groups, right? So because we do all the work with Indian Health Services, we had a particular focus on the American Indian and Alaska Native risk. We definitely are, as an organization, we would like to shine a light more on these outcomes. We know that the outcomes are really related to that socioeconomic stances and the environment that a patient is living in. So we are elevating the sort of outcomes, the overarching outcomes, but then we're also doing the next analysis, which is really figuring out what are the other drivers and like what can we do to help explain and help provide action steps so that it's clear how to reach out, how to help, and how to solve the problem, right? So it's a clear difference, and it's an incredible sort of a staggering result that if you're looking at areas that have a higher population of Alaska Native and American Indian, you're seeing that the cases are rising at a faster rate, and there's definitely a difference, and then also the deaths per 100,000 are rising at a very high rate. The next thing that we're drilling into as a baseline is that we're trying to gather the telehealth data, right? So what ideally we'd like to be able to pull telehealth data out so that we can see the pre and the post and the in between, right? So that if we're able to see how people are using telehealth, how are they using face-to-face visits, and what are the outcomes associated with it. So, and the next layer here is to figure out how do we tie all this information together. So we have our pre-world defined. We're drilling into it more so that we can start seeing when we want to build out a comparison group. Another layer here is that we do want to figure out, are there vulnerable populations that are just not getting, not having the same sort of telehealth or access that other groups could be having, right? So particularly if there's like areas of that just don't have the internet connectivity, or they just don't have the ability to log in, how does that impact outcomes? So that's another sort of our baseline gathering area. And then our case monitoring, right? So this is a map of the Portland area in Oregon, right? So we're able to look at the zip code outcomes for the number of COVID cases per 10,000 in Oregon. Those are the green dots. We're able to see the, and all we did was underlay the concentration of patients that have three plus chronic condition or comorbidities for COVID-19. So you can see that there's the kind of wide spectrum of patients that have a lot of these conditions versus the ones that just don't have as many of these conditions, right? So you're able to kind of overlay that information. We can see where those hotspots for risk are, but then also where the hotspots of actual cases. The other piece that we always layer on is thinking about the other sort of indicators, right? Pulling in the census data that gives us some demographic information, but then also gives us some economic information, right? So if you look over on the right-hand side, you can see how the income per household, as that rises, the number of cases per 10,000 decreases. But there are some outliers. So there are specific outliers. Because this is a PowerPoint slide, I just wanted to call out the specific outliers with a box. And particularly, we chose the percentage of population that is Alaska Native or American Indian. And you can see that there is one zip code that has a higher sort of proportional population. That is a Warm Springs area near Mount Jefferson in Oregon. And you can see that their rate per 10,000 is a lot higher than the average, which is about 15. The rate is about 42.6. We did the same thing for the percentage of the Hispanic population, and you can see how it rises up, and there's a really big outlier, right? So we wanted to make sure that it was really highlighted. So as we're thinking about the different ways to parse and cut the data, we want to be able to show and really highlight the different outliers. Another interesting trend is as we're taking the persons per household, you can see that there's an upward shift. As the number of people in a household increase, the rates per 10,000 increase as well. So all of this information, some of it is public source, some of it is we're pulling in, we're pulling in together census data. We're also pulling in publicly delivered data, but then also we're pulling in the Medicare and the all PRL claims for Oregon so that we get a deeper dive into that data. So one of the other things that we're able to pull, because we are a quality improvement network and we contract with CMS, we have access to the NHSN, so the National Healthcare Safety Network. We're able to see the reporting that for individual hospitals and nursing homes. So we have deferred rights for many of these hospitals and nursing homes. So we're able to drill in even more. So we can see this is a generic nursing home or generic hospital, so you can see an example, but we can see by collection date. So which collection date is very helpful for us to be able to say, when did the actual diagnosis occur? So when did the COVID patient actually present? When did a death actually happen? And then how is capacity changing over time? So we're able to see that this first window is just showing you the number of patients. The next window is showing you the capacity of beds. So as it's trickling up to 100%, you can see where patients need more services and more resources. And then you get in the lower quadrants, you're able to see the bed capacity and the ventilator capacity. So we're pulling this information together proactively so that we can help kind of identify trends, but then also identify where there's areas of, really marketable, major improvements versus areas where you're seeing trending upward and you want to make sure that there are services being pushed to those areas. So what are the other analyses that we're working on that just don't fit into a snappy sort of like data visualization, is that we're really looking at the risk, building a risk model to predict patients that will have complications for COVID on individual populations, right? So if we think about it, there's could be, you know, different populations live in different states, right? We have a ton of data across 6 different states. We want to make sure we're building it correctly for each individual population, and the mix of sort of chronic conditions versus non-chronic conditions, right? So how this would be applied is that it would enable state agencies, but also clinicians, to be able to really prioritize what they would like to be able to, which patients they want to reach out to first, so that you're seeing that there's the patients that are at the highest risk. They might be the patients that you reach out to first, versus patients that you can kind of be able to access through telehealth or other means, or maybe, you know, it could be the way that you're designing your practice. We're also modeling the impact of deferred care on key cohorts, in particular congestive heart failure, diabetes, behavioral health. How do we show that having deferred care actually impacts outcomes, right? So I think this really enables the clinicians to be able to triage how to work their patient panel so that they're able to mitigate those effects of deferred care. And then finally, just another analysis that we're building out is the telehealth, right? So if we think about telehealth and you think about what are the best uses for telehealth, it might be your very severe chronic patients. It might not be, right? So I think what we're trying to do is test out the hypotheses and then be able to show information back to practices so that they're able to design a new plan for how they would implement telehealth as a long-term approach. So these are just some analyses that we've pulled together. We'd love if you wanted to chat in on anything else you'd like to learn more about. If there's additional things that you're like, I would love to know this because you have this type of data, we'd love to be able to share it with you. Lisa, are we seeing any questions? Yeah. So Lisa Miller added a few of the things that we're already thinking about, which are the high-risk patients, Indian Health Services, so that Alaska Native American Indian and population, and how do we shine a nice light on that, and then also the COVID monitoring over time. So if there's anything that you have that you'd love us to drill into more, we'd be happy to share and model out that work.
There's a question about the Native American, Alaska Native data. Does it include only Medicare recipients?
No, for this one actually, so if we go to, I'll go back to these slides. So these slides are provided, Indian Health Services actually reports this information. So they report the information daily. So we pull that data daily directly from their website, and then we blend it with the other data that we have so that we're able to show you know, and we know that we're not, we know that it's a sample, but it could be, it's a representative sample. So this information comes directly from IHS and it's public on their website.
A couple more questions have come in. Joseph asks, is there a frustration index that is measurable and thus predictable for adverse social behaviors?
I have not heard of that.
I have not heard of one, but that would be a fascinating thing to try to develop.
That's a really good idea.
James asks, what are the limitations to relying on claims data and what other sources are we looking at?
Yeah, so for there definitely are limitations in claims data, right? So we're only seeing the things that are going through a claim line, right? So that's very difficult to try to triangulate and create a full story of what's happening with patients. So what we're doing is we're investigating other data sources, which include HIEs, so our Health Information Exchange, that have some clinical data, particularly when we're thinking about how do you look at a diabetic patient without knowing any of their lab results over time, right? So then you don't know if they're a complex patient or if they're a relatively controlled diabetic. So I think those are the types of things that we're trying to blend in, plus public data sources as we're we're stretching the limits of the census data as much as we can, and then we're pulling in as many different types of data sources as possible.
And another question about data availability, Carolyn asks, is there any information about adolescent well visits and immunization gaps, or is that only available for Medicare age patients?
So in Oregon, because we have that data available an all payer claims database, we can definitely pull that out. We can investigate pulling down as long as a state has an all payer claims database, we're able to pull that information and start investigating. We can also start researching if there's a need to look at immunization registries and figure out how do we start reporting and blending some of that information.
Ooh. This one's interesting. Erin says, how do we find data analysts to help us in our practice? I've been wanting to hire a data analyst for a couple of years, but don't know how to find someone who has experience with healthcare data. You may know some analysts who are out of work looking for something.
Yeah, there's definitely analysts everywhere. I would be happy to kind of help you find someone and also help you figure out like what to look for when you're doing interviews. We're also happy to extend help if you need it. During this sort of time of transition.
And specifically, how does someone find this information for Idaho for COVID?
For COVID, I'm not sure if there's public reporting for Idaho and at what level, but we can definitely research that and figure out if there's a, what's the data that is most reliable, depending on your need, if there's a certain way that you want to look at the data. We have Medicare data readily available for Idaho, but we're also able to kind of drill in if there's a specific question. We can definitely figure out how to answer it.
And do we have number of ICU beds per county?
Yes, we do, because there's a provider of service file that is free and open under CMS. So we use that provider of service file that gets updated regularly to be able to pull that information together.
Great. Craig asks, is there a way to help prioritize contact tracing resources with this data?
Yeah, and Jeff, is that something you want to speak to? I know it's something that you're passionate about.
So we are looking into how one would set up contact tracing. And so this is an interesting mix of public data and the type of data that can be assembled through care management software, because there's individual data that have to be gathered on each case. You have to figure out, first of all, where they live. You need to know who they've been in contact with, and then not only do they need to be contacted to find out what they need in order to stay in isolation as cases, but also then the contacts need to be contacted and need to be supported in being quarantined. And so there's a lot of issues there. There are social issues and issues that have to do with community resources. So the data challenges of this are huge. But what it also provides is a level of individual information that can be merged with the large data sets that Meredith has spoken about. So we're really exploring this. I think it's a wide open field right now, and there's a lot of room for innovation here. But I'm really optimistic that we can find some ways to create some very usable dashboards that will be useful in real time for health departments.
All right. There's a question about antibiotic use. Is there something about the uptick in use of hospital antibiotics and expectations of resistance in COVID patients? I think the question is that something we have looked into or could look into?
Yeah, I definitely think it's something we can look into as we start getting more of that data. I think that makes sense to start seeing if what happens with the uptick, do outcomes change? Yep. Mm-hmm. And I do see the question about Idaho. So that's one we can take back and try to research so that we can help you figure out the hotspots in Idaho.
Mm-hmm.
Yeah. Mm-hmm.
Okay. So yeah, I think let's ask the last question and then we'll move on to the next presentation. So With the increased rate of infection among poorer financially challenged groups, for example, the Warm Springs Reservation, what have we gleaned related to transmission method? Does it differ from the general population, extended care facilities, et cetera?
Yeah, I think that's the information we're trying to drill into now is like why is why are the rates so different? We have drilled into a little bit for Navajo Nation just because the infrastructure is different, right? So it could be that it's because the infrastructure setup is different, how readily available is water. I mean, there's a ton of different factors, and what are the other types of vulnerability that could be presented in that environment. So that is kind of our next stage, is like, how do we drill into that information so that we can show this is the path towards improving the outcomes. And then should I be handing it over to Sarah now? So Sarah Halvick leads our analytics services team, and she is going to walk through what's next and what's on our roadmap. But a lot of your discussion is actually really helpful because then it leads into where we're prepping for. So this is fantastic and very helpful for us.
It is, thanks. So as we move into thinking about what comes next, I wanted to revisit the waves again, just quickly. So we know that the first wave of impact is that immediate morbidity, mortality from COVID-19. The second wave is the impact of resource restriction on urgent non-COVID conditions. The third wave being the impact of interrupted care on chronic conditions. Many of you called out diabetes and other chronic illnesses earlier. And the fourth wave being mental illness, trauma, economic injury, and burnout. Again, many of you called out behavioral health and staff wellness there. And underlying all of this are the more vulnerable populations. You called out the homeless populations, frail elderly, and other groups at high risk, including the underserved. So we recognize that these waves will probably not be four singular nice waves as they are depicted here. We added another first wave part 2 there, you can see, because we anticipate multiple first waves, and we anticipate multiple resulting second, third, fourth waves. And we don't know how long these waves will continue going, maybe months, maybe years. But we do know that these waves will continue to overlap and repeat. Next slide. So as we think about these waves and the impact and how we're planning ahead, these are our key focus areas. So we recognize that with COVID-19 come new needs. There's increased need for telehealth, deferred preventative care, health services capacity planning, and cost modeling and practice redesign. The meaningful analytics that would be appropriate to address each of these new needs are different. So what we have here are some of the different ways that we can address these. Some of these questions might require a capacity and utilization planning focus. For example, using data to provide insight on how we plan for new waves of COVID-19 and predict new utilization patterns. Some might require a population health analytics focus. That is, how are pre-existing conditions exacerbated by isolation and physical distancing? Other questions might lend themselves to cost analytics. What are the long-term financial impacts of fewer face-to-face encounters for primary care clinics, for example? Other questions would really benefit from a research and evaluation and the rigor that approach brings. For example, how has the COVID-19 pandemic affected patients with a history of substance abuse? And finally, some questions might benefit from care gap and quality measure analysis. For example, examining the quality impact of deferred care or late care for patients with chronic conditions. And this is especially tied to the cost analytics. As we know, there's been a move to value-based purchasing, and much of that relies on results from these quality measures that we anticipate will be pretty significantly affected. Next slide. So our process for approaching any important question is to start with the user. So first defining what is the problem that you are trying to solve and who is the audience for this work. Once that's clear, then we move on to the job to be done, which is why are we doing this and how are we doing this? Before we move finally to the output, specifically looking at what do we want to achieve and what are we doing? But this process always starts with the user. We always start with the user first. Next slide. So this is where we want to hear more from you. We want to make sure that our analytics are providing meaningful insights and not simply adding noise. We know there's a ton of data out there. We know that there's a lot of reporting, and we think that we have important data that can provide meaningful insights. But we want to make sure that that is truly useful and we're not adding noise and confusion to an already crowded airspace. So we want to know more about what questions you have for us and what topics you would like to hear about in future webinars. So if you could please chat in your responses now.
While we're waiting on those responses to come in, there were a couple questions from earlier that we wanted to circle back around to. So one of them was, has there been an impact of providers' ability to coordinate care of patients due to COVID and lack of face-to-face interaction?
I think, Jeff, I think you're out there in the field talking to folks.
Well, the world of telemedicine is rapidly changing, and I think we're on a steep learning curve. One thing that has become clear is that a lot of clinical medicine can be handled really well telephonically. And I think it's going to be hard to put that genie back in the bottle once this settles down. Patients tend to do really tend to really like the service of not coming in. They feel safer, and if their needs can be met, then I think it's all indications are that there's very positive experience from telemedicine. Clearly, some things cannot be handled. I personally had the experience where I had to share a skin lesion with a dermatologist and make an appointment to have it removed, but that can be accommodated. And then you basically come to the clinic, and you're the only one there. So I think the experience has been really good. We will see. I think it's too soon to have a full analysis, but I think all the early indication is that we can do a whole lot more remotely without office visits.
And there were a couple of other questions. How can we predict when and if we no longer need masks or 6-foot distancing?
Yeah, I think, and Jeff can probably speak more to this, is like as we're thinking about the sort of reopening process, right? So as we have really close contact tracing and the ability to really manage that community spread, right? So you really need to lock in on where are the areas of the outbreaks versus where is the area of general community spread. So I think that's one of the pieces that it's going to require a lot of sort of data gathering. I think that's the worry that I have, is like, how do you start knowing that you have enough information and that information is correct and reliable over time. But Jeff, definitely speak more to that.
Well, I mean, there are two aspects to this. One is that we're going into this world in which we want to open things up and we don't know what's safe, and the lag time is like weeks. So it's sort of like having a car that you adjust the steering wheel on and you only see how much it turned, after a while, which can be pretty dangerous. And so that's part of it. The other part, though, is that we don't even know. We need to be able to respond to different phases of an infection. So there are different dynamics in different communities depending on how much community spread there is. So in other words, if a community is fairly free of disease and a new case comes in and is spotted, that lends itself very well to contact tracing and basically finding everybody that one or two contacts infected or may have infected, and that can suppress an outbreak. And I think what we're probably moving into is a phase where these things are all going on at the same time. You have some communities that have been quiet and then start up again, both in terms of economic activity, but also disease activity. And the question that we have to be trying to figure out is out of clamping down in distance and what's
Jeff, you're breaking up for us. Maybe you could turn off your. Jeff, you're breaking up. I wonder if you turn off your video, if it would work better.
Yeah, I will do that. Let me see if I can get out of. Okay. Well, we'll try this, but just to conclude, I think we're heading into a period where there will be a lot of different things going on simultaneously. So our job is to create dashboards that allow the public health departments and people making public policy on maybe even on a local level to make decisions about what do they need to do to protect the community at any given point in time.
There are a couple of questions expressing concern about the future of especially independent practices and what the healthcare delivery system could look like going forward. I think one question was around what policy and payers might be able to do to help ensure that we have an adequate delivery system going forward.
Sarah, is that something you would want to speak to?
Yeah, I mean, I think it is a complicated question that would pull on probably every aspect that we presented in that earlier slide about, that could be a practice transformation study, that could be an economic impact study, that could be a research study. I think it's a complicated question that would pull from many different data sources and is, probably answerable in some shape or form with limitations. So how's that for a non-answer? I definitely don't have an answer to that, but I think it's a question that we could address with some of the data and capacities that we have.
And we have about 4 minutes left on our call, so I think I'll pop up just a couple last questions here. There was a question earlier from Donna. We shared data that was based on Medicare fee-for-service, and in some markets, Medicare Advantage has a pretty broad saturation. Does that change, change the findings or the applicability of our analyses when they're based on only Medicare fee-for-service population?
Yeah, I think that's something that we include is like, is it a good enough sample to actually extrapolate out into like what the actual indicators are, right? So I think that's where we've been cautiously kind of walking into different geographies, saying, do we have the right data to answer the right questions? I think that's my biggest fear, is that if you take data that's just Medicare fee for service and try to extend it to a general population, you can't do that, right? So you have to think about like what is the question you're trying to ask, and does it help meet that specific question? I do think that as we go into different geographies, we want to start pulling in those all payer claims databases. We want to make sure if we can get access to the Medicare Advantage data, it could be a few iterations to proving the importance of that data and proving what we have already been able to do with other data sets, so that we can build on the analyses and create more robust findings.
All right, and then I think our last question will be around how do we reassure patients that it is safe to go back to a provider's office and try to minimize the impact of not seeing patients and not seeing providers on the second and third waves.
I think I yield to Jeff and Sarah too, but I think for our world, we're thinking about what is the data that we can prove that there is there is safety in those sort of interactions. As a first pass of like, what is the information that we can collect to prove that there are no outbreaks stemming from a particular event or service, right? So, but I do know that, Jeff, you're thinking about the way to do, telehealth and practice redesign is like, how do you think about the different ways of approaching patients? So if it's if it's effective to be able to meet them in a telehealth setting versus a face-to-face setting, then that's probably the best approach. Or having multiple teams that are trading off different times so that they're able to meet the patient's needs, but then also be able to be protected at the same time.
Yeah, I think this remains to be seen. I think this is sort of the great unknown we're going into, and a lot of it has to do with public perception, as well as the prevalence of disease in any particular community. But I think pre-screening, asking the right questions, I think there may be a role, for, at least in advance of any procedures that need to be done, of doing testing. But in terms of how do you protect the practice, you do it by setting up the office so that people are not having unnecessary personal contact. And you might separate your team so that if one does become exposed, that the others are not shut down.
And I think just in an effort to wrap up and save your time, I think we already talked through our ideas and questions, but I did want to alert you to the last slide. We do have COVID analytics on our website, but we also have our new product development director is Megan Haggard, who's been one of our chat masters. She is happy to feed in any of your ideas or questions. We'll also be going through these questions that you've been asking just to make sure that we can follow up on anything that you're in need of. So we don't want you out there needing things that we can definitely help you with. So feel free to reach out to Megan. Feel free to connect with us at any time. We're so happy that you came.